Good evening, residents. I know you all must be tensed up for the practical exam, but let me provide rapid approach to diagnosis in respiratory case examination. We are going to discuss 9 commonly asked cases in your practical exam. I hope this will serve as your last minute revision. Suppose there is a patient with the following findings: increased VF, impaired to dull note, bronchial breath sounds, crepitations. And if at all the history is short and patient is febrile, mostly think of consolidation, probability of bacterial pneumonia. On the other hand, same clinical findings, long history, constitutional symptoms, right-sided trachea with right-sided drooping. This can be either right fibrocavity, right fibrosis with pulled trachea, probability of tuberculosis. Most of you can recognize all these findings clinically. But when it comes to provisional diagnosis and when it comes to the examiner asking you, why do you think this is the diagnosis? This is how you have to articulate your clinical examination findings, correlate with history, and then tell why this is the diagnosis. Then, if at all patient is having baseline respiratory symptoms, suppose shortness of breath every time it is present, but now it got exacerbated, history of inhaler or nebulization use with or without pedal edema, widened subcostal angle, resonant note over body of sternum, expiratory wheeze, smoking history. This has to be COPD with or without cor pulmonale depending upon the findings. Then the fourth case, either previous history of tuberculosis with pleural aspiration history, volume loss features, or remote trauma history to the chest. Then this you should think of pleural thickening fibrothorax. Elderly, smoking history, venous obstruction features in the sense SVC obstruction, dilated veins, drooping of right shoulder, absent breath sounds on the right. This is possibility of right-sided collapse, malignancy with SVC obstruction. This is examiner's favorite case. Then prior TB, on and off infections were there. There is clubbing and on auscultation, coarse, creaky, leathery crepitations. This is nothing but your bronchiectasis. Long history, dry cough, basal crepitations, extrapulmonary features. Say for example, there is joint pains or rash or features of scleroderma. All this should make you think about ILD. Then eighth case, elderly, smoking history is there, trachea is towards right, absent breath sounds on the right with the stony dullness in the bases and intercostal bulging. This is nothing but right collapse because you can see tracheal deviation with effusion, and this is a possibility of malignancy. And sometimes you will have the same findings, trachea might be central, then also you should think of dual pathology, collapse with effusion, usually with malignancy. Then the last case, history of right pleural aspiration, trachea is towards left, stony dull note in lung bases, shifting dullness, and a straight line of dullness on percussion. This generally happens whenever, suppose they have taken a case for pleural effusion and they have preserved for exam, but the patient was symptomatic. Some intern prior day has put a needle and aspirated. Because of aspiration, now air can enter and these findings might be evident, and this is nothing but a case of right hydropneumothorax. And always your common sense, common science must be your main approach. Suppose your senior says that this is a pleural effusion case, don't think only pleural effusion might be present in that patient. If somebody has aspirated few hours ago, it might get into right hydropneumothorax. And by chance, if there is no significant mediastinal shift, there might be underlying collapse also. Always you depend upon your common sense and what are the findings you are presenting at that point of time. Accordingly, you give your diagnosis. Coming to the last minute tips, always examiner is right. If at all examiner feels this is the diagnosis, please do not quarrel with him at the final presentation. Common things plus common sense, like I told you, is more than theory knowledge or recent advances in case presentation. This happens generally. You might miss findings which are very common, such as clubbing, such as lymphadenopathy, and you will be answering about biologics, recent advances. Examiner is not worried about these in your final exam. He is only worried whether you can handle this case without any recent advances also. Practice case sheet writing and plan your differential diagnosis properly. Stay cool and composed. Try to answer to the point and don't miss common things. Have a positive mindset and try to express what you have learnt till now. In case of any errors, don't let it affect your further performance in other cases and viva. Do your best, leave the rest, and all the very best, students. And I am always thankful for all the residents of the country making this course the biggest resident course for pulmonary medicine or respiratory medicine postgraduates in our country. Always indebted to that. Thank you, and any doubts you can ping me on this number. All the best, students.